inviting me to this conference and a wonderful place. And when I got the invitation to talk in this conference, I looked at the title. It was very surprising because my first case of Delhi, which is published in Liver, where Dr. Sheila Sherlock requested for the reprint, is diclofenac hepatitis, where it came from Kerala. Dr. Vishwanath sent it. It was in the early 90s when we published, I think probably in 94. And it was a pleasure for me to give that talk in this place. And Kerala is always special to my heart, and that means the gastroenterologists and hepatologists from here has always been sending me a lot of biopsies to Vellore, and also from Karnataka, various states I used to get. But Kerala cases were always very interesting, which recently in Coimbatore Pathology Conference, I think Dr. Ashim is there, I've shown quite a few cases from there. So it's my pleasure to give this talk here, okay? Thank you. And I'm at present in the SIMS Hospital as head of Department of Pathology. And as you can see, the DILI can cause a spectrum of acute and chronic liver injury. It can mimic any liver disease. No single diagnostic test is available. The diagnosis mainly by correlation of the clinical and pathological findings and exclusion of other etiologies. And you have the classification. The broader classification is intrinsic and idiosyncratic. Intrinsic is otherwise a predictable or true hepatotoxins. Larger proportion is for individual exposed to these drugs. You can have again direct and indirect. Direct is directly affecting the cell organelles or cell membranes. Indirect is either producing intermediate metabolites or affecting the metabolic pathways. There are few dose-dependent intrinsic toxins. For example, paracetamol and aspirin, which is more common in Western countries, which produce acute liver failure, but in India, I think it is more of rodenticide-induced acute liver failure. Coming to idiosyncratic, unpredictable, it occurs in a smaller proportion of individuals, where the immunological idiosyncrasy is again classified as autoimmune, which is chronic hepatitis-like, or immune allergic mechanism. The second one is toxic metabolite injury. This is because of the metabolic aberration of the host or production of some or accumulation of the toxic metabolites. Mechanistic idiosyncrasy is represented by the checkpoint inhibitors and also function of the drug's mechanism of action. Immune allergic, it develops after a short sensitization period, usually about 1 to 8 weeks. It recurs on re-administration, also produces symptoms of hypersensitivity. And the liver biopsy may show a mixed hepatic and cholestatic injury, may be eosinophil-rich or granulomatous inflammation. It may also result in Rett syndrome. I've given some examples of those drugs. Some drugs can also development of antibodies can occur, and cell-mediated injury, you have HLA subtypes in many drugs. Toxic metabolite-dependent injury, it's not accompanied by hypersensitivity symptoms or reproduced by re-administration, appears after wide varying periods of drug exposure, so it can be very difficult to diagnose this. It can range from 2 weeks to several months. Injury is due to reactive metabolites, acute delay in some cases. Some degrees of dose dependency can occur. For example, instead of 10 milligram, if you take 50 milligram per day, and also if the drugs involves more than 50% of hepatic metabolism, then it can result in severe liver injury with a very high enzymes elevation, acute liver failure, and death. And then coming to morphological patterns of injury, it can replicate any type of liver disease. It can injure all cell types, but particular attention you have to pay on the hepatocytes, bile duct epithelial cells, and endothelial cells. The type depends on the particular drug. You can have a necrosis, apoptosis, cholestasis, steatosis, and so on. Severe injury can result in pulmonary hepatic failure. Subacute and chronic injury can lead on to bile duct loss or fibrosis. A recovery from acute DILI, it takes longer if it is cholestatic, that is more than 16 weeks, compared to acute hepatocellular necrosis, which can be from any time between 4 to 12 weeks. Chronic cholestatic injury can lead on to fibrosis and cirrhosis. Recovery may be very slow even after withdrawal of the drug. The patient can have a persistent elevation of ALP, and also more than 50% of these patients can have a ductopenia. And the hepatocellular type of injury, that is when you have more hepatocellular necrosis, it is to be associated with a poorer outcome and a higher mortality. Cholestatic injury can also be associated with a significant mortality. Mixed liver cell injury is supposed to have a lowest mortality rate. If there is an eosinophilia and biopsy, it's supposed to have a higher rate of recovery. And I've given some tables which has got various drugs are listed here. Just for quickly, I'll go through this. So you can have an acute necrosis which can be zonal, and acute hepatitis like mononucleosis or chronic hepatitis like or granulomatous reaction, some drugs. You can have a cholestatic which can be a bland cholestasis, or you can have a chronic cholestatic injury which can be a ductopenic or which you call a vanishing bile duct syndrome, and biliary sclerosis and mixed hepatocellular and cholestatic injury. And also steatosis, which can be micro, macrovesicular, steatohepatitis. Classical example is amiodarone, which is used for cardiac problems. And vascular, again, more of the steroids can cause anabolic and oral contraceptives, sinusoid dilatation, pileosis, obstruction syndrome, and so on. Fibrosis and cirrhosis, methotrexate, and drugs which can cause chronic injury. Neoplasms, all drugs are listed here. So I'm going to show some few cases where you have 28-year-old female present with a history of fever for 2 weeks followed by jaundice, known case of seizure disorder and psychotic disorder. She was on anticonvulsant, antipsychotic drugs. We didn't have any detail beyond this. As you can see, there's a high bilirubin and a high enzymes and high alkaline phosphatase, while markers were negative. And this shows, you can see I marked here, there's a perivenular cholestasis and I'm not sure. The pointer, this one, sorry. And this is a perivenular cholestasis, and you can see some pale staining xanthomist transformation of hepatocytes. And this is the portal tract with, you see quite a few hepatic arterioles, but there is no, every hepatic arteriole should be accompanied by bile duct, at least 80 to 90% you should have. And here, if you take about 10 portal tracts, at least 9 portal tracts should have a bile duct. Here it is all, many portal tracts didn't have bile duct. And this again, there is a mild steatosis, and you have a meson trichrome. We didn't find much fibrosis in this case. So the diagnosis of prolonged cholestatic injury with ductopenia and focal mild steatosis. We said it's keeping with the drug-induced cholestatic injury. After that, I just asked for some details on this. A patient has been on 4 to 5 years on all these drugs. What the drugs I have highlighted, almost all these drugs can cause chronic cholestatic injury and also vanishing bile duct syndrome. I'm not sure. Actually, the patient was investigated for various hospitals. Finally, when it came to SIMS, it was diagnosed as DILI, and then they did a biopsy. This is what, it was a referral patient from somewhere. And case 2 is 50-year-old female with abdominal pain and jaundice of 15 days joint pains with high colored urine and pale stools, diagnosed to be diabetic 2 months before. All viral markers were negative. Here also again you have a high enzymes and high bilirubin level. And the biopsy showed, you can see the marked bridging necrosis, a lot of inflammation here. And this is a mixed portal inflammation. You can see quite a few eosinophils. And here there's a completely gone, you have seen lot of bile ductal proliferation. And again, this is a higher power showing eosinophils mixed inflammation. These are the astaphil bodies in the parenchyma. And this is a panel, shows the reticulin stains. There is a complete loss. There is a reticulin condensation. This is a osine stain, and the color looks a little different because it's the old case. You can see this is elastic fibers which is normally present in the portal tract. All these bridges, there is no fibrosis. So indicates it's recent. So this is a TJLB biopsy, which you have moderate inflammation, bridging necrosis, and bile ductal proliferation. These are suggestive of probable drug-induced liver injury of recent onset. So on further detail, found out this patient is on 10-elliptic-induced hepatitis. Some of these DPP-4 inhibitors can rarely cause cholestatic. Sitagliptin, Saxa, and vildagliptin, all these can cause this injury. But fortunately, I got the follow-up because my husband happened to be the hepatologist there, so I got all the detail before coming here. 1 month later, the patient, as you can see, the enzymes have really come down to normal. It is very difficult to get any details in a corporate hospital. Case 3 is a 65-year-old lady with a progressive jaundice in 2 months, abdominal distension of 10 days, and is also taking native medicines for more than a month. And so clinically it was suspected DILI, and you can see all those enzymes and all the other markers were negative. And this again, you can see there's much more than the previous case, a lot of bridging necrosis, hardly anything. And this is the, and here you can see there's a lot of inflammation. There's a cholangiolytic within the cholangioles, bile ductules, you can see the neutrophilic infiltration within them. And also these are ductular cholestasis. With the ductules, you can see the bile stasis. And this is a reticulin collapse. This is a Van Giesen. Generally, if there's a recent, you will not find this fiber. There is some immature collagen. Or saying this is the elastic fiber, but here there are some pale staining fibers. So there's not mature fibrous tissue. It's a little more than acute. So there is an extensive parenchymal loss with a reticulin collapse, some immature collagen deposition, collagen. So it's suggestive of more of a acute subacute hepatic injury. Drug and toxic injury is a possibility. We found out that patient has been taken Ayurvedic treatment both as tablet and also an IM injections. This is a case 430. This came just 2 weeks ago, referred from some other hospital in Chennai. This is a 33-year-old male with the complaints of yellowing of eyes and jaundice. Had taken medicine somewhere else, but no improvement. He has also given a history of taken whey protein 2 months and testosterone for 1 month. When I asked, they said probably for body development. So the CT showed a hepatosplenomegaly. You can see the CT appearance, which has been reported as diffuse hepatic steatosis and gallbladder wall thickening, no calculi of fluid retention. Investigation again, high bilirubin enzymes are not that very elevated. All the markers were negative. And as you can see here, the lot of sinusoidal dilatation. There is a perivenular cholestasis. And you can see the higher part showing the bile plugs, not much inflammation. The Van Giesen showing cholestasis. Sinusoid dilatation with marked congestion. This is a mesentericum showing some fibers around the sinusoids. So there is a moderate perivenular hepatocanal cholestasis with minimal inflammation and venous and sinusoidal ectasia. This is suggestive of a recent onset cholestasis, probably drug induced. As I've shown in the table, anabolic androgenic steroids, oral contraceptives, all these can cause acute cholestasis, sinusoid dilatation, congestions, and neoplasms, and so on. So we advise them not to touch any of these hepatotoxic drugs or the herbal medications causing liver injury. This is the, I'll just quickly go through because this is just another case of itraconazole induced. I just wanted to show you some examples of each categories, but not everything because it's not possible. Here I think it was already on itraconazole. And here again you can see there's a lot of perivenular. Compared to the previous case, there's a lot of inflammation also in the perivenular zone. But otherwise, there's no fibrosis, I think, marked cholestatic hepatitis. So with lobular perivenular inflammation. So itraconazole has been shown to have inhibition of bile canalicular phospholipid transporter. It can affect MDR3 and ABC4. It's already been reported in the literature. And this is the case coming to, which I was saying, from Kerala. 53-year-old lady, 2 episodes of jaundice. First was in 6 months prior with the fever and vomiting. I was told the patient was admitted in Mumbai. Maybe those days in 92, I think people are talking about hepatitis C when this just was coming. But then second attack from Kerala, Dr. Vishwanath sent me the biopsy to Vellore. And it was a 1 week duration. The history, I just had medication for joint pain. And but then finally when I said, because the details were not given, just like Dr. Jayanti said, I used to write in letters and to the clinicians out of Vellore, and they'll get a reply from them. There's no phone call, no this thing, so all by letters. You know? I wish there was a pigeons or something which you can fly it over with the letters. But this is the wonderful thing which I had from the clinicians outside Kerala, which they used to respond. And he sent the patient along with the medications, came to Vellore. And then I said, it must be diclofenac. I found there's a patient, attender came, it was taking over. And the patient's second attack, she was almost under pre-coma. Then I told them not to touch this drug and send back. I must tell you, Dr. Vishwanath came to CMC and told my professor, Dr. Date, Dr. Bhanu saved our patients because patient himself was stopped and then readministered. These are the close association which I have it along always with my clinicians, which was, I was hoping to see Dr. Vishwanath here, but I think I have not seen him. So on inquiry, the patient was taking 50 milligram diclofenac 3 times a day, 7 weeks prior to first attack. So I think when she had a jaundice, she herself stopped and then started again, then again developed to this. She became very serious actually. And then she improved by second week and it took by 7 weeks. And this is in those days no color picture. I just had from my publication, I took out this, which was this one which Dr. Sheila Sherlock wrote in her own handwriting asking for reprint, which I preserved it for a long time. I don't know, somewhere I misplaced. I considered that was really a privilege to get a letter from her. And these are some studies from India, but mostly United States, from the Western Europe, where they have said amoxicillin is most common, then followed by antituberculous. We have Dr. Ashrat here, who has published a lot of on Delhi. Our study in India and also the National Registry has shown antituberculous to be of 70% compared to other things. They also state, and I think in this study from St. John's, 17% is mortality, but the National Registry is 12.3%. And these are the first 6 topmost drugs that they have given in the Indian network studies. And so again, combination of hand. So I forgot to tell the previous study in this Dr. Koshi from Kerala. On the other hand, he has said Ayurvedic statins, antituberculous comes into third. So these are the drugs, and 10% with idiosyncratic can lead to acute liver failure. And from study from India on genotype, they found ultra slow acylated type NAT26 genotype a risk factor for anti-TB delay. We have found some 50 to 60% this may probably contribute to tuberculosis inducing delay. To summarize, liver biopsy can be helpful by either confirming delay or suggesting an alternate explanation. Pathologists need to identify the pattern, then correlate with other things, and sometimes you can have a mixed hepatic pattern. It can be more than one etiology. And detailed history is essential. Time interval is known. Other cause of liver diseases to be ruled out. Delay superimposed on pre-existing liver disease need to be understood. The offending drug should be withdrawn immediately if it is supposed to be the causative agent. And ultimate proof is a re-challenge. It is conducted only just like the diclofenac in those days. She has taken it and we know it was a causative, but otherwise it's very difficult to re-challenge. Treatment is largely supportive, and prevention is ALT monitoring, biomarkers, and HL subtyping on certain drugs. Thank you for your attention.
So Bhanumati, thank you. Are there any questions from the audience? Any questions?
Is there any feature suggestive of the drug-induced liver injury and DIAH, drug-induced autoimmune hepatitis? Any features which can differentiate?
No, that's why I told you. There are something like when you have autoimmune hepatitis, like you can get in drug-induced also. I have not given that because of the time limit. I've just shown most of them I get is a cholestatic or hepatocellular injury. Autoimmune, sometimes you can get some plasma cell inflammation and also antibodies, certain drugs which I listed, you can get it. The one difference between idiopathic and this drug-induced is once you start them on steroids, then after the drug is withdrawn, the steroids and the drug-induced autoimmune hepatitis should subside after the drug is withdrawn. Unlike the real autoimmune hepatitis where the steroid needs to be continued, this is the one which say if it is a drug-induced autoimmune hepatitis, the patient will recover after giving whatever the course of steroids and the drug is stopped. And that's the way you can differentiate between the two.
Thank you, ma'am.
I just want to know, when should we do, how early can we do a liver biopsy in an acute hepatitis if we think of how early should we do? Will it change over time?
No, I think so. That's why I said basically when any patient comes with acute, you need to rule out all your, based on the clinical parameter, rule out all the viral markers, and also to go through the history of medications, because very often the people are not giving the herbal and other medications. Very often if they say arthritis, this in the 90s, because arthritis, I thought when I saw the bridging necrosis, eosinophils, immediately I thought it must be. This is my first case after returning from Australia in the 90s. So I wrote and asked. So, but nowadays you have very easy for communication, you can always ask them. But not all patients will get eosinophils. But when you have a bridging extensive necrosis, usually you think of only the drug will definitely come apart from your viral markers. So depending on the scenario, if you have a doubt if everything is negative, then you have to do it, then find out. And then the biopsy also shows then immediately. Drug is something which you can stop immediately. If it's a long duration, if you wait, the patient can, like diclofenac, if they have not done it, the patient was almost second dose hypersensitivity, she became very sick.
But it was the second time. What does Dr. Harshad feel? Because we calculate the R and we say hepatocellular pattern and cholestatic pattern. Then we wait, withdraw the drug. And then when
most diagnoses can be done clinically.
Yes.
Yeah.
So it's only when you have some diagnostic dilemmas, when patients have where the history of drugs is not very well known, or it's not well forthcoming, and also some rarely for prognostic purposes. So you have some undetermined liver disease, then you think it is a suspected drug-induced liver biopsy, and if there's extensive necrosis, then you know this is a worse liver disease. Whereas if there is only eosinophilia or granulomas, then you can prognosticate that perhaps these patients have a better prognosis.
Thank you.
Both eosinophils and granulomatous are supposed to have a mild injury. Eosinophilia is supposed to have better recovery.
Madam, suppose if the history and clinical features are not available, is there any definite histological finding to suggest that it is due to drug injury in the pathologist specimen?
See, it's a good question. I will not release my biopsy report without extracting the clinical because you can see it. Suppose in acute case, if there's a lot of eosinophils, you can suspect. If there's not much eosinophils, only a bridging necrosis and thing, we can say it is acute. Okay, if the chronic, again, we use certain, that's why the pathologist has to find out whether hepatocellular, biliary, what kind of pattern, we'll try to correlate, and then we'll ask the clinicians. Even in the chronic hepatitis pattern or biliary pattern, some of this like PBC, PSC and all, it's very difficult. Unity lactoctopenia, then we look at the clinically, the age and other LFT functions, and then we have to, the pathologist should not sign out the report without getting the clinical details. I will not do it till today for liver biopsies, okay? Though I practice in corporate hospitals, fortunately my husband is there, so I can get, but many other cases coming from surgeons and all that is very difficult to get. They just leave on just biopsy, that's all. No clinical information is available. But to people who sends me liver biopsies, they know that I demand all these things. If I don't, then I'll call up and ask them. Okay. Otherwise, liver, it's very, very difficult. So without clinical details, we'll be burning our fingers. So it's better not to release. Okay.
Yeah, definitely, ma'am. I just want to add one point. We can give it as a hepatic pattern of injury or cholestatic pattern of injury. We can give it, and clinical correlation is advised.
No.
But my question is...
no, that I think I will not like to do it because many things we are writing kindly correlate clinically. Because like even if you have whatever is available, drug history is not available, then that point I will say suggestive, like I was putting there, no? Recent on, suggestive or recent onset injury, probably drug induced to correlate clinically and also to suggest follow-up.
There are possibilities included.
Yeah.
Ma'am, sometimes it is very difficult to differentiate between the seronegative AIH.
Yeah, I think we have a
Yeah, AIH is coming.
Okay.
Next to talk.
So you can
Okay.
we can discuss a quick question and a quick response.
Yeah.
Madam, one question is this chronic exposure to this toxin, how much duration is needed for to develop cirrhosis like that? Any data?
Oh, no, that is not because it's, you even call it a chronic one based on your, if it is following your LFT and all that. Some people say 3 months, some 6 months. The study I think you have taken as a 6 months kind of duration. But how long it takes, it depends on the type of the drug. It's very
Sometimes
difficult.
it is difficult.
But generally, if you have all these anticonvulsant, antipsychotic drugs, they have almost like a PBC, PSC like pattern. It will take long time, but you sometimes it will not recover. Even the histological ones, you have ductopenia, it will be very difficult to get back the ducts.
Is
So
there
that can,
any-
over the period of time, it can
Is
develop.
there any data on the chronic exposure to pesticide leading to cirrhosis?
No, I have not really gone into that kind of things. Maybe Dr. Arshad will be.
Yeah, we can discuss this
Yeah,
after
later.
we have another
Yeah.
session coming up.